Good afternoon. I am Fadela Shaib, speaking to you from WHO headquarters and welcoming you to the virtual press briefing of WHO on global health and humanitarian issues. Today, we have several people online and in the room. Let me introduce people who are in the room. Dr. Tedros Adhanom Ghebreyesus, WHO Director General. Dr. Mike Ryan, Executive Director, Health Emergency Program. Dr. Maria von Kerkhove, the Director ad interim for Epidemic and Pandemic Preparedness and Prevention. Dr. Abdi Rahman Mahamud, Director ad interim for the Alert and Response Coordination. Dr. Zhong Wenjing, Unit Head Global Influenza Program. We have also several experts joining online that I will introduce in due time. But let me just tell you that we have two WHO representatives online. Dr. Rick Pieperkorn, WHO representative Occupied Palestinian Territory, and Dr. Shibel Sahbani, who is the WHO representative in Sudan. If I may, I would like to ask journalists to address their first question on Gaza and Sudan to take advantage of the presence of the two WHO representatives online, one from Jerusalem, another one from Khartoum. Thank you so much. And now, without delay, I would like to ask Dr. Tedros to address this press conference in his opening remarks. Dr. Tedros, you have the floor.
Yeah, thank you. Thank you, Fadila. Good morning, good afternoon, and good evening. First to Gaza, where we're deeply concerned about Israel's increased military activities in Rafah, where most of Gaza's people have fled for safety. An estimated 30 to 40,000 people have left Rafah for Khan Yunis and Deir al-Balah, but more than 1.4 million people remain at risk in Rafah, including 600,000 children. Already one of Rafah's 3 hospitals, the Al-Najjar Hospital, has had to shut down, and its patients have moved elsewhere, and hospital staff are removing supplies and some equipment to safeguard them. The Rafah crossing from Egypt into Gaza remains closed, which is a major access point for supplies into Gaza. Fuel that we expected to be allowed in today has not been allowed in, meaning we only have enough fuel to run health services in the south for 3 more days. WHO has pre-positioned some supplies in warehouses and hospitals, but without more aid flowing into Gaza, we cannot sustain our life-saving support to hospitals. WHO has no intention of withdrawing from Rafah and will stay and deliver alongside our partners. WHO is coordinating the work of 20 emergency medical teams in Gaza, comprising 179 internationals from 30 countries working alongside 800 local staff. These teams are embedded in 10 existing hospitals and have established 5 field hospitals. They have provided almost 400,000 consultations, performed more than 18,000 surgeries, and added more than 500 additional hospital beds. They're working at all levels of care, in the north and south, providing trauma stabilization, delivering babies, supporting early warning for disease outbreaks, and so much more. With support from WHO and hospital staff, emergency medical teams have cleaned up Nasser Medical Complex in Khan Yunis following an attack and siege earlier this year. They have recruited health workers, and the hospital is ready to start receiving dialysis patients today. A ceasefire is needed urgently for the sake of humanity, and WHO calls for removal of all obstacles to the delivery of urgent humanitarian assistance into and across Gaza at the scale that is required. Now to Sudan, where more than a year of fighting has left the country facing a humanitarian disaster. More than 15,000 deaths and 33,000 injuries have been reported since the conflict began in April last year. 15 million people are in need of urgent humanitarian health assistance. Almost 9 million people are displaced, half of them children, with extremely limited access to health services. More than 70% of hospitals in conflict-affected states and almost half of health facilities in the rest of the country are not functioning. Those that are functioning are overwhelmed by people seeking care, many of whom are internally displaced. Health facilities, ambulances, health workers, and patients continue to be attacked, depriving entire communities of essential health services. Just last week, 2 of our colleagues from the International Committee of the Red Cross were killed in South Darfur. The conflict has led to a devastating deterioration in food security. More than 1/3 of the population is facing acute hunger, and there is a risk of famine in Darfur and Khartoum. Humanitarian partners have released a famine prevention plan. WHO's priority is to ensure continuity of health services, to prevent and respond to outbreaks, and to provide care for those most in need, including pregnant and breastfeeding women and children under 5. Access to the most vulnerable remains highly constrained. It's imperative that all sides to the conflict provide unhindered humanitarian access to those in need, including through cross-border routes. In neighboring Chad, an outbreak of hepatitis E has been declared, with more than 2,000 cases and 7 deaths, mainly among Sudanese refugees. WHO has deployed a team to support the response. Most of all, we call for a ceasefire and a comprehensive peace process for Sudan. It's time to silence the guns and raise the volume for peace. The best medicine is peace. Now to the United States and the outbreak of H5N1 avian influenza among dairy cattle. So far, 36 dairy herds have been infected in 9 states. Only 1 human case has been reported. At least 220 people are being monitored, and at least 30 have been tested. However, many more people have been exposed to infected animals, and it's important that all those exposed are tested or monitored and receive care if needed. So far, the virus does not show signs of having adapted to spread among humans, but more surveillance is needed. The virus has been detected in raw milk in the US, but preliminary tests show that pasteurization kills the virus. WHO standing advice in all countries is that people should consume pasteurized milk. Based on the available information, WHO continues to assess the public health risk posed by H5N1 avian influenza to be low, and low to moderate for people exposed to infected animals. In recent years, H5N1 has spread widely among wild birds, poultry, land and marine mammals, and now among dairy cattle. Since 2021, there have been 28 reported cases in humans, although no human-to-human transmission has been documented in that time. WHO has a strong system for monitoring influenza around the world through a network of influenza centers in 130 countries, 7 collaborating centers, and 12 reference laboratories with the capacities and biosafety requirements to deal with H5 viruses. We also have the Pandemic Influenza Preparedness Framework to support the rapid development and equitable distribution of vaccines in case of an influenza pandemic. However, no similar system exists for other pathogens, a gap that WHO member states are now seeking to close through the pandemic agreement. The outbreak of H5N1 in dairy cattle also demonstrates the importance of a One Health approach that recognizes the intimate links between the health of humans, animals, and our environment. These two systems, one to prevent outbreaks and epidemics through a One Health approach, and another to respond to outbreaks by sharing vaccines, are two vital elements of the pandemic agreement that WHO member states are negotiating as we speak. I'm encouraged that all 194 member states are strongly committed to finalizing the agreement in time for the World Health Assembly. They're working long hours to find common ground in good faith for the people of the world. Finally, yesterday we launched the 2023 WHO Results Report, summarizing our work over the past 2 years. This interactive, comprehensive report, available on the WHO website, shows the depth and breadth of our work, with 174 dedicated country pages, 100 country impact stories, and more. It also provides transparency on where our funding comes from, where it's going, and what it's doing. The report paints a mixed picture of the state of global health. We have many reasons to celebrate. For example, since the turn of the century, child mortality has fallen by half, thanks largely to vaccines. But due to the disruptions of the COVID-19 pandemic, vaccination rates fell, and we're seeing a resurgence of diseases like measles. We have 7 years remaining until 2030, the deadline for achieving the Sustainable Development Goals. Some are on track, many are not. WHO will continue supporting all countries to strengthen their health systems in pursuit of our founding vision, the highest attainable standard of health for all people as a fundamental right. Fadila, back to you.
Thank you, Dr. Tedros. I would like now to open the floor to journalist questions, starting with Lauren Pelly from CBC. Lauren, do you hear me?
Hi there, I can hear you. Thank you. Yes, Lauren Pelly with CBC. On the H5N1 front, there are many countries that don't have access to vaccines for this virus, let alone stockpiles. And I'm just wondering if the WHO has any major concerns over if we did see human-to-human transmission of this virus, how prepared countries and drug makers be to scale up and provide vaccines if they were needed?
So perhaps I'll start, and I think Wenjing should come in on this. So I just want to contextualize the question that you have. You did add this into your question, but I want to contextualize the situation that we're in. As the DG has said, there's been 28 human cases of H5N1 since 2021. There's been 1 human case of H5N1 in the U.S. associated with contact with dairy cattle. There's a lot of ongoing work that is happening. We are asking for more surveillance to be conducted in animals, in poultry and wild birds, now in dairy cattle, not just in the U.S., but globally. And of course, people that are occupationally exposed to infected herds need to be tested, they need to be provided care. All of that type of work helps us do these risk assessments to understand the virus, its circulation, and if there are any changes in the virus. As you pointed out in your question, we have not seen human-to-human transmission of this particular virus, this H5N1. However, we do have a system that is in place. It's based on the Global Influenza Surveillance and Response System, or GISRIS, and also the PIP framework that we have, the Pandemic Influenza Preparedness Framework that came into effect in 2021, GISRIS has been in operation for 70 years. And through those systems, there's an ongoing risk assessment of the viruses, looking at the viruses themselves, the different mutations, the characteristics of those viruses. And through that system, there are candidate vaccine viruses that are recommended to be considered for production. And within that system, we have two that are H5N1 viruses that could be used to ramp up vaccine production. We had not triggered that system yet. We do not need to trigger that system yet. And through the PIP framework, through the relationships that we have with manufacturers, we have access to real-time production of H5N1 vaccines should those start to be produced. And so there's a lot of work that's in place in terms of the production, in terms of ramping up those capacities. But again, we haven't done that. We haven't triggered that in place. There are billions of vaccines that could be produced within the first year, if necessary, based on the manufacturing technologies that we have. And WHO has worked on agreements with the manufacturers to have approximately 10 to 12% of those vaccines in real-time production should we need, to be distributed based on risk and based on need. So I just want to highlight that there is that system that is in place. It has not been triggered. We don't need to trigger that system. But that's based on a lot of work, a lot of relationships that are in place. And as the DG has said, we have this system in place for flu, and we don't yet have that for other pathogens.
So just to add to what Maria said, is that to ensure that we do have a system in place, if human-to-human transmission occurs, and if a pandemic starts, the system will be triggered to take a serious response. As Maria said, that there's ongoing risk assessment and the update of candidate vaccine viruses. So for the current H5N1 in cows, we have two, but we also need to bear into mind that there are also other clades of H5 virus circulating, and we also have candidates for these other clades of H5 viruses. And it's not only H5, they could also be H7, H10. So all these candidate viruses are being updated by the system and being distributed to vaccine developers. So once the situation warrants, they will be triggered into action to scale up the production. Also to add that this system also producing reagents to enable the release of the vaccines. To add that for the seasonal influenza, there's an influenza program in place. So the deployment system also in place in countries that could be used for the pandemic response. As Maria said, that if we look at the seasonal vaccine production capacity, we will be able to, of course, on the assumption of the similar antigen dose, as well as the egg supply, for example, all smooth, we will be able to have more than 8 billion doses. That's the best scenario of estimate. And this only take into consideration of the existing platform, licensed platform. There are also other novel platforms are under development, and there are also vaccines in trials. So this is something I want to add. Back to you.
Can I just add very briefly, again, from what Maria and Wenjing have said. First of all, this virus has been under very tight surveillance since 1996. And that global network of laboratories who work all around the world, including our colleagues at CDC Atlanta, are extremely vigilant in the way they've shared information and specimens through the PIP framework, and to have candidate vaccines in place and to have manufacturers in place ready to produce vaccine. And you may ask out there, well, why don't we just produce the vaccine now? Well, first of all, we've got to make sure it works against this clade, which we believe it does. And again, I think our colleagues at CDC in Atlanta are testing human sera of people previously vaccinated with H5 vaccines to look for that cross-reactivity and make sure that the candidate vaccines would work. And secondly, we produce hundreds of millions of seasonal flu vaccines every year, and we would have to switch production. So it's not, you can't just press the button and begin producing pandemic H5 vaccines. You have to stop producing your seasonal vaccine, and all of you out there know how life-saving that vaccine is, both in the northern and southern hemisphere. So this is not this requires a very careful consideration, as Wenjing said, to determine whether this virus does switch. Again, the virus spread very rapidly around the world. This time, not in humans, but spread very rapidly. This particular clade, the 8.3.4.4.B, is that it? No? Not quite. 2344B. It spread around the world very, very quickly. And that's what's, in a sense, concerned us, that this virus did spread very, very quickly around the world, and it has moved from avian species into mammals in different settings, and in particular, in this case, in the US. But the fact that we know that, the fact that we're observing that and working with our colleagues in the agricultural sector, but again, we would, on a day-to-day basis, working with our colleagues at the Centre for Disease Control at Atlanta, and we thank them for the wonderful work they're doing. But they also have to work with the state-based system in the US, and that requires states, and there are 8 states involved here. So again, no more than WHO working with member states. The US federal system has to work with the states who have their state public health architecture, and they in turn have to work with agricultural authorities across all of those states. And that requires very smooth, efficient, and standardized work across many sectors. And that's the trick with One Health approaches. We speak about One Health approaches and we talk about that process. But when the reality hits, the fact that we have to work across sectors, we have to work between federal and state-based systems, we have to work between national systems and global systems. That's the trick of cooperation, getting all of these systems that are inherently designed to work by themselves to work together. And I think the global influenza surveillance and response system, to me, is one of the greatest examples of how the world has overcome that inefficiency in how we do business and actually created a very efficient, very, very strong system for managing this and many other avian viruses over the last 75 years, Vinjing, is it? 70? I'm getting all my numbers wrong today. 71 years. Thank you.
Thank you. Now I would like to invite Mohammed Arslan from Anadolu to ask the next question. Mohammed?
Thank you so much, Fadila. As Mr. Tedros mentioned, Rafah border crossing remain closed since yesterday. Kerem Shalom crossing also closed. My question is, if this process got longer, do you have an alternative plan to deliver aid Gaza as WHO? Thank you.
Thank you, Mohammed. Dr. Pieperkorn may take this question.
Thank you very much. I didn't get the last part of the question. Can you read the last part of the question?
I said, if this process got longer, do you have any alternative plan to deliver aid to Gaza as WHO? Thank you.
Okay, thank you very much. As we all know, this process should not get longer. And just actually describing as the DG did, so currently the border crossing, Rafah crossing, is closed for, and I want to, maybe the most important element, what we all need humanitarian is fuel. Then, of course, also for humanitarian aid, but also staff movement and medevac. So I want to stress again, without fuel, all the humanitarian operations, including hospital operation, they come to a halt. In the south, our estimation is that hospitals only have fuel for 2 to 3 days left. And we should talk about expanding humanitarian operation. And not, again, that because of this escalation, on top of an escalation, and with this insecurity and the lack of fuel. So it's not only that nothing comes into Gaza, but there will not be movement in Gaza. So we have WHO, we've suspended our missions to the north now for the coming week because of the lack of availability of fuel. We cannot move the EMTs, etc. And I want to stress a few other points. So at the moment, today, the UN sent an assessment mission to Kerem Shalom, which took almost a whole day. Currently, there is no fuel. There was discussions that fuel would come in through Kerem Shalom. The current status is just that there's no fuel coming in today. So anyone with influence on that is the biggest well, it's the biggest item. It is absolutely needed. I'm not only talking about minutes. Think about food and food distribution, but think about fuel for bakeries, fuel for hospitals. We discussed that. Fuel for any operations. And what I maybe add a little bit on this. We Al Najjar Hospital, and the DG was referring to that. It has become a non-functional hospital, and we have seen this constantly. When hostilities increase, when military incursion takes place, that hospitals, they are, and Al Najjar was right on that line, that hospitals, patients cannot reach the hospital, staff cannot reach it, ambulances cannot reach it, we as WHO and partners cannot bring supplies. So very quickly that hospital becomes from partly functional, non-functionals. We've seen this in the north, we've seen this in Khan Yunis, we've seen it in the middle area, and we see this now in the south. There are 3 hospitals in Rafah. So Al Najjar, non-functional. I was in my last lengthy mission, I was there from 8 till 23 April for 3 weeks, and this hospital had more than 200 inpatients. It provided services. It was the main dialysis services for southern Gaza. It provided dialysis to 700 patients. Before the crisis, only 60. During the crisis, expanded to 700 patients. Some of the equipment has been moved from Najjar to other field hospitals and to Nasser Medical Complex. So what's WHO doing and partners? I want to stress it again. With this military incursion, which is now taking place, when there would be a full military incursion, people talk about restricted military incursion now, when it would be a full military incursion, we are planning, we have a contingency plan, WHO and partners. So at that stage, we expect that all the other 2 hospitals, there's one other mother and child hospital, the Emirati hospital in Rafah, and a Kuwaiti hospital, that they will become dysfunctional as well. So then we are only left with a few field hospitals along the coast, in the Mawassi area and in Khan Yunis. There was a referral hospital, Al-Aqsa, that is in the middle area, and you have the European Gaza Hospital. Unfortunately, the European Gaza Hospital will not be reachable then. It will be isolated. So WHO and health workers, partners like I want to mention the UK Med and MAP UK and MSF, France, UNFPA, UNICEF. We revived Nasser Medical Complex, which was non-functional a couple of weeks ago. And at least now it has again an emergency department, a surgery with 9 operation theaters, and maternity and pediatric ICU, and some dialysis. WHO provided medical supplies and now also 15 dialysis machines to Nasser Medical Complex. That hospital will be opening today. Well, one of these days it will open. It's actually already partly opening. Then expanded field hospital, but I want to stress the point, and maybe one point is important. This contingency plan is like a band-aid. When there's a full incursion, it will not avoid the excess mortality and morbidity we expect. Over to you. Apologies for my long reply.
Thank you. Dr. Ryan?
Yeah, thanks, Rick. And just to follow on, because the journalist asked what are the alternatives, and really and truly, the Kerem Salam crossing, which is now closed, and the Rafah crossing were the 2 main lifelines for supplies getting into Gaza. There is a crossing in Erez to the north, but to my knowledge, Rick, you can confirm this, that's not fully functional, and it's certainly not fully functional for humanitarians, and it's certainly not providing supplies into the south. And there is a pontoon-based solution that's been proposed and is being built by the US government, military, but that is not functional yet. So it's very hard when Rick uses words like this has been characterized as a restricted military incursion or a limited offensive. And the first act of that offensive is to cut off the 2 lifelines to 2.5 million people in Gaza. The first act is to stop the fuel, stop the food, stop the medicine at source, at the border. I don't call that limited, and I don't call that restricted. I call that a re-imposition of total blockade on nearly 2.5 million civilians who are already starving, who are already dying from preventable diseases, and who need our protection. So while it may be characterized by others as a limited offensive in order to appease the political views or interpretations of others, this is not limited if you don't have food. This is not limited if you don't have fuel to run generators in hospitals, and this is certainly not limited if the whole humanitarian system effectively collapses in the face of this. Thank you.
Yeah, maybe I can confirm what Mike says. So the entries in the north, they will not be. It will not work for the south, where the majority of the populations are, and as you read, the maritime corridor is not yet functional. So the two issues, the Rafah crossing, Kerem Shalom crossing, have to open as quickly as possible. But WHO did as well for ourselves. So we had, as you know, warehouses in Khan Yunis which were destroyed. Then we had opened 3 warehouses in Rafah, which are functional. We opened also a huge warehouse in Deir el-Balah. Most of our supplies we moved from Rafah to Deir el-Balah, and we started to pre-position supplies at the still functional hospitals. But again, this is what I call band-aids. It will not be enough. It will not help avoid the substantial additional mortality and morbidity we expect when a full-scale military operation will take place. So that's, of course, the most pregnant request.
Thank you.
A ceasefire. Over to you.
Thank you, Dr. Pieperkorn. I would like now to invite Christiane Ulrich from DPA to ask the next question. Christiane, you have the floor.
Thank you very much, Fadela. And I'm sorry to contribute to the jumping here, but I'm going back to H5N1. Can you help us a bit with the risk assessment? Is it only a question of when, not if, there will be human-to-human transmission? Or how do you rate the possibility that this will not ever happen? And if it does happen, isn't it also a possibility that the virus will be totally harmless in people, and people will just have mild symptoms, and that's it? Thank you.
No, nobody is suggesting that this virus will be the new pandemic virus. I said before, we've been tracking this since 1996, and everyone thought H5N1 would be the next pandemic, and it turned out to be H1N1. Which was a totally different reassortment that emerged in a different part of the world, right? So the idea that you can predict based on this, the reality is, though, and this is the reason why, this particular virus, this highly pathogenic virus, spreads very easily amongst birds. It is thought that, in general, pandemic viruses emerge through reassortment of avian, human, swine strains of virus. In other words, these viruses exchange genetic material, and at some point along the way, a virus emerges that can cause transmission from human to human, with either high mortality or low mortality. Nobody is suggesting that H5N1 is the new next pandemic. I don't believe anybody can predict that. But it's certainly concerning when a virus like this begins to infect multiple mammalian species, which means the virus is adapting to mammalian species, which are more like us than birds, and therefore there's a higher level of alert. A higher level of alert does not mean a prediction that this will become a pandemic, but we must remain vigilant. Maria? Benji?
On the risk assessment part, I mean, it's a good question because these risk assessments are ongoing. There are many different things we take into consideration. The latest risk assessment that we published on H5N1 we did together, it was WHO, WOHA, and FAO, our sister agencies that work on animal health or focus a lot on animal health. And so what we're looking at is how this virus is circulating in different species, whether these are animal species, as Mike has pointed out, Wenjing's pointed out, poultry, wild birds, domestic poultry, small mammals, marine mammals, land mammals, in humans. And we're looking at those circulations. We're looking at the characteristics of the virus, and we don't take anything for granted. We look at the genetic sequence of the virus. We look at the mutations that are there, but also how the virus behaves, if you will. Viruses are not alive, but in terms of their severity, their transmissibility, and how we need to prepare. Wenjing may want to speak specifically on flu, but we as WHO, we work in scenarios. We try to think through all of the different options that may happen to make sure that we have the preparedness plans in place, we have the readiness plans in place. And many countries are now actually revising all of their pandemic preparedness work because of flu, but also because of COVID. And so making sure not just surveillance is strong, not just vaccine pipeline systems are strong, but clinical care, making sure that we have access to personal protective equipment, that we have evidence-based guidance around all of the different public health and social measures versus the medical countermeasures that we need. So there's a whole pipeline that's in place, and we think through these scenarios to try to make sure that our member states are ready for those different types of scenarios. But we don't operate in fear. We don't operate in always a worst case scenario, but we have to keep that in mind. But I just wanted to highlight that these risk assessments are constantly ongoing. We do them regularly with partners around the world. It's not just WHO that does this. We work with virologists and epidemiologists and clinicians and many different disciplines around the world to do this in real time. But it's based on the information that we have, which is why those partnerships in human health and animal health, environmental work are critical.
Dr. Zhang, please.
So just to add that when we are talking about risk assessment, we need to be very specific. Risk on what? Risk associated with what? So here we are talking about that virus at the moment circulating, detected in cows in the US, the risk of this virus to become human-to-human transmissible in humans. This is a risk assessment we were talking about, and we assess that the risk is low. But at the moment, this is this form of the virus, and we know influenza virus is constantly changing. So if for this virus to become a pandemic virus, it will undergo a lot of changes so that it could transmit easily among human to human. You also asked about whether the next pandemic could be harmless or basically whether it will be mild or severe. So first, as I mentioned, for the pandemic influenza virus, we really need to take one step back. Not just that particular clade at the moment in US, B313. We also need to bear in mind there are also other clades. It's called 2321C, also is circulating and infecting human in Southeast Asia. That's H5. In addition to H5, I already mentioned we have H7, we have H10. So these are avian viruses. Aside from avian viruses, we also have swine viruses. It's called a variant, which caused the 2009 pandemic. So the global system, we basically keep all these viruses under monitoring and continuing doing the risk assessment, continuing update the candidate vaccine virus, so that when situation warrants, the response could be triggered immediately.
Thank you so much. I would like now to invite the next journalist, CNN London, if you can just please identify yourself. Can you hear me? No. So let's go to the next journalist, and we will come back to our journalist from CNN London. Next journalist, Helen Branswell from STAT. Helen, go ahead, please.
Thank you, Fadela. I think this question is for Dr. Mohammed. Do you have a word yet whether the suspected Ebola case in Burundi is actually Ebola, and any details about, I think there's a suspected second case? And while we're talking, can you tell me where is vaccine, and can it be deployed quickly to the region if it's needed? Thank you.
Dr. Abdi, please.
Thanks, Helen. We are aware of 2 suspected viral hemorrhagic fever cases from southern Kivu in Democratic Republic of Congo that were referred to Burundi. The first case sadly passed away was a 9-year-old child, passed on 2nd May. Samples was collected from there, and immediately the government have started the investigation on collecting samples on 2nd May. So far, we received a few challenges with the flight in transporting those samples, and the team, the country office, the ministry was able to send the samples to DRC in Goma to be tested. As we speak, the lab is conducting the test, and hopefully the government will announce whether it's negative or not. But as you know, we have to also send our samples to a WHO reference lab for the final confirmation. Because of the detection of the suspected viral hemorrhagic, the government increased the surveillance unannounced, and improved surveillance led to detection of several cases. We had a second child, a suspected 8-year-old, who's in a stable condition. Initial samples was also taken, but that child, as we speak right now, is in a stable condition. Contact tracing have started, almost 20 contacts for the first case, 25 contacts. But more importantly is the situation in DRC. As you're aware, DRC has been responding to multiple outbreaks of Ebola. They do have the response capacity, and they've started the investigation, send a multidisciplinary team there and conducting where the child came from. Around 75 contact has been traced, and the team is out in the field. So in summary, there's close collaboration between the two countries. Our team there in the field office, regional office, are supporting the government, and once we have, we will share with you. And we will really like to appreciate the Minister of Health Burundi, which came out with all the information in a transparent way, and all the teams that have been supporting this investigation. Thank you.
Dr. Ryan?
I'd just like to reiterate Dr. Mahmoud's acknowledgement to the three governments, the government of Burundi, who were very speedily reported this case before confirmation. Some of the delays that have occurred in transporting samples have been logistic. They have not been political in any way, and we really do commend the government for that openness and transparency. To DR Congo for immediately on being notified by Burundi, sending a team to the field and immediately beginning to preemptively identify contacts. So what we're seeing is, and also on the Burundi side, the identification of contacts of at the community level, but also the healthcare workers and the IPC measures put in place on both sides. So we're seeing really standard textbook activity occurring in an area of difficult logistics, and that's where we need to provide more support, so these teams have the support they need to do the job they're doing. And then to Uganda, UVRI in Uganda, the Virus Research Institute of Uganda, which provides an excellent service not only in Uganda but across the region, and has multiple platforms for making diagnosis of viral hemorrhagic fevers and other dangerous pathogens. So again, we're seeing sub-regional mutual support, transparency between countries, sharing of information, sharing of samples, and vaccines are available and are ready to dispatch should the need be, and we have plenty of vaccines in stock to be able to deal with this. But remember, we only have a vaccine for Ebola. We don't have a vaccine for Marburg virus. We don't have a vaccine for Sudan virus. So we will have to wait and see whether this turns out to be really a VHF. If it is a VHF, does it turn out to be an Ebola? And if it's Ebola, is it one of the two most common strains, Sudan or Zaire? So we wait to see. But again, the right actions are being taken, and sometimes you can take the appropriate actions long before you know what the final diagnosis is, and that's what we really like to see, and we just like to commend the governments of the three countries for doing that, because that's what saves lives, is taking immediate and decisive action.
Thank you so much. I would like now to invite Frances Vinal from Washington Post to ask the next question. Frances?
Good afternoon. Thank you. Yeah, my question is on Gaza. We're looking at hospital capacity throughout the Strip, and I was hoping you'd be able to share the names of the hospitals that are currently functional. I think the last update was that there were 12, but with what the Director General was just saying about Al-Najah, maybe it's now 11. But yeah, it would be great if you were able to share specifically which hospitals, not including the field hospitals in Gaza, are currently at least partially functioning.
Dr. Pieper-Kohn, are you still with us?
Yes, I'm still with you. So at the moment we talk about, I was also actually wondering, is this 12 out of 36 hospitals which are what we call partly functional or 11, we can provide you the whole list. But when it comes to the south, so in Rafah, as the DG mentioned, Al-Najjar Hospital is not functional. Then there's two other hospitals which we fear when the military incursion would be proceeding, and that is the Emirati Maternal and Child Hospital and the Kuwaiti Hospital. So currently, the hospitals which are functional, I call them partly, we call them partly functional. None of them are fully functional. In the north, you talk about Kamalat 1, Indonesian Hospital, Al-Ada, Jabalia, Al-Ahli, Arab Hospital, and Al-Sahaba Hospital, and Al-Hilu International Hospital. All of them are relatively small hospitals, I can tell you, because as you know, Shifa Hospital was the main hospital there and it's non-functional. And in the south, you talk about Al-Amal, partly where Kuwait, also European Gaza, Al-Aqsa, and Al-Hilal, Al-Emirati. That's the Emirati. We call it the Mother and Child Health Hospital. And we hope that will definitely happen. Nasser Medical Complex will be partly functional as well. Over to you.
Thank you, Dr. Pieperkorn. Francis, we will also send you by email the list of hospitals this afternoon. So this will be helpful for you, I think. Thanks so much. I would like now to ask Alexander Tin from CBS to ask the next question.
Hi, thanks for the time. On SARS-CoV-2, can you tell us more about KP.2 and vaccines? Is anything being done to look at KP.2's mutations against antibodies or in vivo? And then on H5N1, can you expand a little bit on that kind of production ultimatum you were talking about earlier? Why is it not possible simply just to fold that CVV into a new seasonal quadrivalent? Thanks so much.
I would like to invite, yeah.
Sorry, I have to look up my notes on the KP.2 because we're trying to pull this together. All right, Wenjing, you go first and then I'll pull up my notes.
Yes. So with regards why we cannot just click the button and put the virus, change the virus itself. So there are a couple of reasons here. First is that, as probably you know, that at the moment, all the vaccine productions are ongoing to produce seasonal vaccines. And there should be a situation that warrants that there's a need to stop the seasonal vaccine production, switch to the pandemic vaccine production. And also in the vaccine production, the plants, they would need to clean out, they would need to take certain procedures in order to start replacing with the pandemic CVVs itself. So this is the reason there's a process in place, and also associated with that is a risk assessment. Whether the situation really warrants the stop of seasonal vaccine production and switch to the pandemic, just to end up with every year, seasonal influenza also kills more than 620,000 at least every year.
Thank you.
Yeah, so the first part of the question asking about KP.2. So KP.2 is a descendant lineage of JN.1. JN.1 is dominant worldwide based on all of the sequences that are shared with online platforms like GISAID. These are analyzed by our technical advisory group for virus evolution. So KP.2 has its descendant of JN.1 and has additional mutations in the spike protein. I won't read them out. And there are other emerging SARS-CoV-2 variants. I just want to point out that JN.1 and it continues to evolve. So we're going to keep seeing these other variants in circulation. Based on the information that we have and the sequences that have been shared, there's about 8% of the sequences globally that are this variant, this KP.2. And the prevalence varies by region for lots of different reasons based on the other waves of infection that have happened, the other variants that have circulated, and the amount of circulation of this virus. The first sequences that were reported were in January this year. So it's been circulating for some time, and we expect these percentages to change. Just wanted to highlight that our technical advisory group for COVID-19 vaccine composition recommended that future formulations of vaccine do include JN.1, but also we state that countries should be using all available safe and effective COVID-19 vaccines according to SAGE recommendations, primarily focusing on people who are most at risk for developing severe disease. So it's one that we are watching, it's one that we are monitoring, and again, reiterate the need for continued surveillance of SARS-CoV-2 in people around the world so that we can monitor this evolution of this virus. The virus is circulating in all countries, it continues to evolve, and for us to do risk assessments on SARS-CoV-2 remains critically important.
Thank you so much. I would like now to invite Paul Adipolu from The Lancet to ask the next question. Paul?
Hello, and thank you very much for taking my question. I would like to ask a question regarding with the focus on gradually shifting away in Africa from COVID as an urgent response. What is being done to ensure that the continent continues to do genomic surveillance and keep track of these new strains as they are emerging? And what is also being done to ensure that these capacities that the continent has in various aspects of responding to infectious disease are also being channeled to supporting the response to non-communicable diseases also? Thank you very much.
So we can go.
Yeah, we can go. So thanks very much for the question. It's an excellent one, and really appreciate you mentioning this, because what we are trying to do as WHO through our regions and through our country offices is to support the capacities that have, especially during the last 4 years, that have been expanded for COVID-19 to deal with COVID, but also to deal with the current and future threats that we face and the future threats that we expect. PCR-based capacity and testing capacity across the continent of Africa has increased dramatically over the last 4 years. The question now is, how is that sustained? How do we sustain the workforce? How do we sustain the financing of these systems? Genomic sequencing capacity across the continent has expanded massively in the last 4 years. And again, how do we sustain this? As demand for SARS-CoV-2 may go down, there's demand for other pathogens for testing and for sequencing and for risk assessment. The capacities on the continent are truly impressive. There are so many countries right now that have capacities in-house, in-country, that could do this assessment, can do the testing, can do the sequencing, can do the bioinformatics, and are actively contributing across the continent and globally to our understanding of SARS-CoV-2. So we are supporting through our regional offices, through our country offices, trying to ensure that we have the financing to be able to support this ongoing activity. It's very difficult at the moment. I mean, I think we need to be very, very realistic about this. The fiscal space for dealing with COVID has shrunk. There are so many challenges that every country is facing. Our press conferences used to just be about COVID, and now they're about war, they're about displacement, they're about Ebola, they're about Mpox, they're about earthquakes, they're about floods. And so governments have to make some very, very difficult choices about what they can continue to do. But for us, we are trying as best we can with all of our partners to ensure that we don't lose these capacities. COVID is not gone, but the legacy of the crisis of COVID needs to be that we have these strengthened systems. Our member states are downstairs negotiating how to keep up these activities for pandemic preparedness, for better responses as we go forward. But there's a lot that we have learned. There's a lot that the entire continent of Africa has taught the world, not just for COVID, not just for early detection of SARS-CoV-2 variants, and the timely sharing of that information, but how to deal with outbreaks, outbreak response. And you've heard some of these examples today. So thanks so much for that question. It's a really critical one with a very, very difficult answer.
Thank you. We are almost at the end of our press conference, but I will take one last question, and this goes to Jane Rigby from Reuters. Jane, you have the floor.
Hi there, thanks for taking the question. The UNFPA says that Emirati Hospital in Gaza has stopped accepting patients. And our question is just, it's probably if Rick Peepercorn's still there, where can women in Rafah go now to give birth? What are their options?
question about the Emirati hospital in Gaza. Dr. Peppercorn, are you online?
I'm online. I didn't get the last point of the question. You mean where patients flow to? Is that?
No, Rick, journalist is saying that the Emirati hospital is closed, and I mean, we know that's the MCH hospital, the one you referred to in the south of Rafah. So it's a mother and child health specialist center.
Okay.
Where do women go now to give birth?
Yeah. Okay, so Emirati hospital is not yet closed. I mean, like, I want to make that point. It's not closed. It's not yet closed, and of course we hope it will not have to be closed. But where will patients go first? There's, as I said, there's a number of field hospitals, IMC, UK Med, etc., which have maternity, and IMC definitely have expanded their maternity services with, again, assistance for WHO, part of UNFPA. UNFPA actually brought in a very good mobile maternity services. We should have had 2 more of these mobile maternity services, but they are stuck at the border. So I think I want to make a plea on that one as well. So then, in Nuseirat, in the little bit further north, IMC setting up currently, and actually it's already set up another field hospital which is specifically focused on MCH, etc. Again, WHO supported with a number of beds, 30 beds, and other medical supplies and equipment. And thirdly, a Nasser medical complex. That I said, it's not just emergency ward; it's also the maternity ward, which will be open, maternity and neonatal ward, ICUs, operation theaters, and a bit of OPD. Of course, again, it will be a big blow if that hospital, which is currently the largest maternity hospital in the south, if that would be non-functional.
Thank you.
But there is some contingency planning done. Thank you.
Thank you so much. We are coming to closing this press conference. You will be receiving the DG remarks this evening, plus the audio and video files of this press conference. The transcripts will be available to you tomorrow morning on the WHO website. With this, I would like to hand over to Dr. Tedros for his closing remarks. Thank you.
Yeah, thank you. Thank you, Fadila. Thank you to all members of the press for joining us today, and see you next time.